This is the reproductive system. It is chapter 27. We're going to start by looking at the male reproductive system, and then we'll go into the female reproductive system. With the male reproductive system, the function is to produce a sperm. That is the male gamete. Gamete are the sex cells. It has 23 chromosomes, so it has half the number because all of your other cells will have 46 chromosomes. So you either have the chromosome that you inherited from mom or from dad, but you only have one copy instead of two copies of it in the gametes, which is the sperm for the males. It's going to also function in transporting that sperm and also for production of the male hormones, the androgen and testosterone. If you look at a cross-section of the male reproductive anatomy, you can see here that some of the structures are external, some are internal. And so you've got the penis here, the scrotum, which is containing the testes, which is where the sperm are actually going to be produced. Then they're going to travel through this, which has either two names. It's either the ductus deferens or vas deferens, depending on which book you pick up. The older name is vas. And then it's going to continue around. As you notice here, this whitish structure right here is the urinary bladder. So the ductus deferens, it goes up, it moves around over top of the bladder, then comes around the back side of it, right in through here. Then it's going to flow through. Underneath the bladder is the prostate gland. And then it's going to, now after it moves through the prostate gland, we refer to it as the urethra. Here's the urethra from the bladder right there. And then it's going to continue on down through the penis and then be expelled out. The testes in the scrotum are not within the pelvic cavity, but below it. We'll explain in a little bit why that is so. And then there are accessory structures, these additional glands. Seminal vesicle, the prostate gland, as I mentioned a little bit earlier, and then this has two names as well, either the Cowper's gland or the bulbourethral gland. So the scrotum, we start there, that is that sac as we just saw, that is behind the penis. It does contain the testes. It is a muscular sac. Sperm production occurs at a slightly cooler temperature than what your internal body temperature is. And so that's why the testes must be located at a cooler temperature outside the pelvic cavity. If they were to be produced at a higher temperature, the survival rate drastically goes down. And the scrotum is divided into two compartments. Each one contains a testis. Testes is plural, testis is singular. So the testes is what produces that sperm, as we just said, as well as the hormone testosterone. Now each testis is going to be divided into little lobules where the sperm is going to develop. It's going to be produced in the seminiferous tubules. So when do the testes descend down into the scrotum? About the 7th month of fetal development is when they will descend down. Sometimes there's complications, and just with age they will descend down. Sometimes they may need to be assisted with surgery to move them down, certainly after birth. The process of making the sperm is known as spermatogenesis. The spermatogonia, those are the stem cells, so that's what the initial cell is. It's going to divide and it will produce what is known as, so here's your single spermatogonium. It will go through mitosis and produce what's known as your primary spermatocytes. It then goes through meiosis. Now, mitosis is a form of cell division we've seen before. Most of your cells in the body carry this out. You start with one cell, you end up with two daughter cells. The two indicates that they have two copies of all the chromosomes. These two new cells were identical to the initial ones. Now, what's going to happen in spermatogenesis is that one of these new daughter cells is going to remain as a spermatogonium to continue this process. The other daughter cell, and just by tradition we call them daughter cells even though we're making sperm, This primary spermatocyte is now going to go through meiosis, which is the process of decreasing the number of chromosomes by half. This only occurs with the gametes, so it's only going to occur with the making of the sperm cells in males and making of the ovum or the egg in females. It's a two-step process. So meiosis 1 occurs, you end up with 2 daughter cells right now. Now you've already split the number of chromosomes by half, and you end up with your secondary spermatocytes. These continue with the second stage, meiosis 2, in which you end up with now what we call our spermatotids. They are all what we would call haploid, meaning they have half the number of chromosomes as to what the original stem cell had. And then these, through the process of spermatogenesis, need to mature and eventually will become the sperm, complete with the flagella that helps them move. So how do the sperm move? So they're made in the testes. Where do they go from there? Well, in the testes, like we said just a bit ago, they are initially made in the seminiferous tubules. That's part of the testes. There they're going to move into what's known as the straight tubules or the tubular recti. From there it goes to the ready testes and then the efferent ductils. All of these are components that help to make up the testes themselves. They're not mature yet. They are non-modal. They don't have that flagella that helps them to move yet. From the testes, they're going to move then into epididymis, which is where they mature, and this is where they gain their motility. After that, they move into the ductus deferens or the vas deferens, the one that I was pointing out to you. It's that thick muscular tube that winds from the scrotum back up into the pelvic cavity around the bladder. This is if a male has a vasectomy, this is what they will cut. So when they talk about snipping things, this is what gets snipped. Because the sperm that are being produced in the testes, if you cut this ductus deferens, it can't transport beyond that point. There's a widening area of the ductus deferens, kind of on the back of the urinary bladder. And that's where the sperm that has been produced, it kind of collects there. It's going to be mixed with fluid there from what's known as the seminal vesicles. Then it's going to travel down the ejaculatory duct, which is what it's called when it passes into the prostate gland. And then from there it continues on down through the urethra. We divide them into names depending on where they are located. Beyond the prostate gland, initially it's called the membranous urethra, and then through the penis it's known as the spongy urethra. So in the testes, this is showing a cross section. So this would be the scrotum. Here is the testes right here with the seminiferous tubules. That's where the sperm, remember, are being made. Here you have the straight tubule, which goes to on the end of each of these lobules, if you will, and connects them to the ready testes, which are all going to flow out of the efferent ductile into the epididymis, which is this almost like a half moon or half circle around the testes. Typically, they're going to travel over here towards the head of the epididymis and then wind around through. They're going to mature. And then from here, this connection, this tubule here, is the ductus deferens. So all of this is in the scrotum. And then the ductus deferens is what is going to lead what's known as the spermatic cord through this cord up and back into the pelvic cavity. There are 3 main accessory glands, the seminal vesicles. That makes up about, all of these are going to produce fluid. This is going to make up about 60% of the semen. It's mostly fructose, which is a carbohydrate or a sugar. That's going to help the sperm, give them nutrients so they survive. The prostate gland is at the base of the bladder. It surrounds that prostate urethra. It produces an alkaline kind of milky fluid. The vagina is very acidic, and so for the sperm to survive in the semen, it needs to be more alkaline to neutralize the acidity of the vagina. And then the bulbourethral glands, also known as Cowper's glands, this also produces fluid. As I said, all three of these glands produce fluid that together make up the semen with the sperm. And this is a very thick, salty type of fluid that helps to clean the urethra because the semen is passing through the same urethra that urine passes through. So you want to clean the urine out. And it also will help for lubrication. So the same picture again, but now that we've talked about the testes, the epididymis are contained within the scrotum. Here is the ductus deferens or vas deferens circling around. Here's the ampulla here, that widening area. Right here is the seminal vesicle that's adding most of the fluid for producing the semen. Here's the ejaculatory duct going through. This yellow or beige color here is the prostate gland. Here's the urethra coming from the bladder. Here's the ejaculatory duct here. They merge together, forming the prostatic urethra, then the membranous, and then finally the spongy urethra as it flows out. And right here, that's the bulbourethral gland right here. So your glands are 1, 2, 3. Just FYI, notice the location of the prostate gland underneath the bladder, and this is a cross section, so it does surround these tubules are passing through the middle of it. So that is why sometimes older males have problems if the prostate gland enlarges. It can start to surround and pinch on the urethra, affecting the flow of urine. So you get decreased flow. Sometimes an enlarged prostate gland, it tends to enlarge as males get older. So sometimes it's nothing to worry about, but it certainly should be checked into if there's a problem because if it becomes cancerous, it becomes enlarged. And so obviously that is a concern. There is a test that they can run, a PSA test, prostate-specific antibody test. Those numbers should be low. As they increase, it's indicative of cancer. And so there's several different treatments that they can use, depending on the level of your PSA, depending on your personal preference, etc. The shaft around the urethra is known, this is the penis, the urethra, as I just said, is known for transporting both the urine and the semen. And so there's, with the fluids, when urine is passing through, no problem. And then in the semen, it does contain some of the fluids from the accessory glands, kind of rinse out to help protect the sperm from the urine. And basically, it's like, let's clean out the passageway before you pass the sperm through it. Circumcision is removing the foreskin or the prepuce from it. That is done sometimes for religious reasons, sometimes cultural reasons. The penis is composed of 3 columns of erectile tissues that, when stimulated, to become more engorged with blood. Testosterone, this is an androgen type hormone. It is a steroid type hormone. Remember, hormones are steroid or amino acid or protein based, so this one is a steroid based. Typically, testosterone is very low in childhood. It tends to start increasing when male goes through puberty, and you start seeing those secondary sex characteristics, starting the increased hair growth, the increased Adam's apple or the larynx, the deepening of the throat, all that. A lot of that is all tied into the increased levels of testosterone that begin during puberty. And this initiates spermatogenesis. If levels of testosterone are extremely low, that can lead to infertility because you need high levels of testosterone to start spermatogenesis. The amount of testosterone is regulated by the hypothalamus and the pituitary glands. It does remain typically fairly high throughout a man's life, so he tends to continue to produce sperm through spermatogenesis throughout his lifetime. With the female reproductive system, the function is to produce gametes, just like we saw with the males. Only obviously now females don't produce sperm. We're producing the oocyte, sometimes called the ovum, also known as the egg, is to produce the reproductive hormones such as estrogen, progesterone. Females also have additional functions with the reproductive system, and that is for supporting the developing fetus should fertilization occur. The female reproductive system, unlike the male, is mostly primarily inside the pelvic cavity. And so if you look at the lateral view here, excuse me, you could see the ovary back here. And from this particular view, it's kind of hard to see your oviduct or uterine tube or fallopian tubes. Here we go again, one structure but with lots of different names. But you can certainly see the uterus is right here. And then the cervix, and then you've got right here is the vagina. So notice something right here. I just want to point out the bladder, the urinary bladder, is in front and kind of underneath the uterus. So when a woman is pregnant and this is expanding, it's pushing down on the bladder. Let a pregnant woman cut in front of you in line for a bathroom. And then, excuse me, from an anterior view, these kind of bluish turquoise color, those are the ovaries. And then you've got the fallopian tubes, or the oviduct, or the uterine tubes, which then are connected down here to the uterus, the cervix, and the vagina. So in terms of the external genitals for female, you've got the vulva area, the pons, or mons pubis, excuse the fat that's over the pubic bone. You have the labia majora and the labia minora. The majora is the skin folds that are just posterior to the mons pubis, that's hair covered with a female that has already gone through puberty. The labia minora helps to protect the urethra and the vagina. The vaginal opening is between the urethra and the anus. So starting anterior, front, females have 3 openings. You've got the urethra, you've got the vagina, and then lastly you have the anus. So once again, here's the urethra, here's the vagina in the middle, and then the anus back here. And this just shows a little bit more of the uterus. This would be the ovary back here. You've got the uterus, the cervix, the vagina. And then once again, looking at it from an anterior viewpoint, you've got the ovaries. Here's those fallopian tubes, uterus, vagina. So the vagina is a muscular canal. It is the entrance to the reproductive tract. It's also referred to as the birth canal. So natural childbirth, this is the canal for the baby to exit from. The pH tends to be acidic. And the reason for this is that that helps to benefit the growth of the microorganisms that you want there. Now, typically we say that bacteria prefer a more neutral to slightly alkaline pH, like pH 7 to pH 8, and fungi tend to prefer a more acidic environment, say 5.5 to 6. But there are some bacteria that do exist quite well with an acidic or a low pH, and that's what we do find here in the vagina, which I will just say, just FYI, when women tend to take antibiotics systemically, so you're taking a pill and it's travels throughout the bloodstream, which means that antibiotics are going to be carried everywhere. One drawback, actually there's two drawbacks that you should be aware of taking antibiotics, is that if they are designed more for bacteria, it can upset the balance, if you will, the normal microbial balance in the vagina. And if you wipe out those bacteria that are supposed to be there, these beneficial ones, you wipe these out and you are setting the stage up to get a yeast infection. The other thing that some people are not aware of is that if you are taking antibiotics, not all, but some antibiotics do interfere with the correct functioning of birth control pills, and so it may make your birth control pills ineffective, and that's something you may want to be aware of. The ovaries. So these are the gonads, the sex producing organs of the sex cells of the gametes. There's a pair of them. They're about the size of an almond, so they're pretty small. They're located in the pelvic cavity, as we've seen from the previous pictures. The ovaries are held in place, in the proper placement, by three different ligaments: the broad ligament, suspensory ligament, and the ovarian ligament. They do contain the follicle, and when we talk about a follicle, we're talking about the oocyte and all of the supporting cells associated with it. There is an ovarian cycle. It's roughly 28 days in cycle. It is not the same thing as the menstrual cycle, but it is correlated to it. The timing of when things occur in the ovarian cycle have to be timed with certain stages of the menstrual cycle, but we're talking about two different things. The ovarian cycle includes oogenesis, which is production of oocytes, and it also is going to include what is known as Folliculogenesis, which is going to be the growth and development of the ovarian follicles. So remember, the follicles are the oocytes and the supporting cells. So oogonia, these are the ovarian stem cells. We're going to start with the stem cells just like in spermatogenesis. Well, in oogenesis, we're going to start with the oogonia, which are the ovarian stem cells. Now, these stem cells are formed during fetal development. And the primary oocytes that are formed in the fetal ovary, they will arrest or they will stop in meiosis 1. And then when a female starts puberty, then the process is going to resume. It's going to start up again. So what this means is whatever primary oocytes were developed during fetal development, that's what you've got. Now, typically you start with about 1 million, and it drastically decreases. By the time even you reach puberty, it has decreased dramatically. The initiation of ovulation is that transition from puberty to reproductive maturity in females. They used to say this age was roughly around 12. It kind of varies, but roughly age 12. Ovulation is going to occur roughly once every 28 days. It is triggered by, you have a surge of luteinizing hormone, the LH hormone. That is going to be what triggers the resumption of meiosis, for meiosis to start up again, and that primary oocyte becomes a secondary oocyte, which then will leave, that secondary oocyte leaves the ovary during ovulation. It's released from the ovary. That's what ovulation is. It's the release of that oocyte. If the sperm is able to penetrate the secondary oocyte, then it immediately completes meiosis 2 and becomes the haploid ovum. Haploid meaning it has 23 chromosomes. So this is where meiosis is really important, that when you have that haploid ovum and the haploid sperm, that when fertilization occurs, you have the two nuclei from each of these cells fusing together, and now they create a diploid zygote. And if you're sitting here going, what is she talking about? What the heck is she saying? All I'm saying is that for humans, and it varies by different species, but for humans, we have, in most of your cells, 23 pairs of chromosomes, or a total of 46 chromosomes. But remember when we were talking about spermatogenesis, I mentioned that the sperm only has 23 chromosomes. Meiosis, you're decreasing that number by half. And why is it so important in meiosis to decrease the number of chromosomes by half? It's to maintain the integrity of the number of chromosomes that you have. So in spermatogenesis, you produce a sperm that has 23 chromosomes. In oogenesis, you produce an ovum that has 23 chromosomes. So guess what? If fertilization is successful, you now have the zygote, that is the new cell from the fusion of the egg and the sperm after fertilization. Well, if you had 23 and you had 23, you now have 46 chromosomes. So you are back to having the proper number. And that's why meiosis is so important, to reduce the number of chromosomes by half. So if fertilization occurs, then you're back up to 46 chromosomes again. If fertilization doesn't occur, that's fine. Both of the ovum and the sperm, if they're not involved with fertilization, they're going to die. And that's okay. That sounds strange to say it dies, it's okay, but it is. So with oogenesis, in this diagram, it's showing you start with that stem cell, that oogonia. It goes through mitosis, just like what we saw with spermatogenesis. One of those primary oocytes is going to remain to produce more. This is occurring during fetal development. See, or before birth even. So now this cell, what happens? It starts to go through meiosis 1. And then it stops. When we say it arrests, it means it stops. So, great. You have a little girl, a nice little baby girl, and it's these primary oocytes just sitting in the ovaries in this arrested state, in kind of this suspended animation, if you want to think of it that way. They're not doing anything. Then at puberty, guess what happens? Because of the changes in the hormones and influx of hormones, it's going to stimulate it now to continue on through meiosis. Now remember with meiosis, when it occurred with the sperm and spermatogenesis, you ended up with 4 sperm cells. Well, ladies, not so with us. What happens is you have your first division to make your secondary oocyte. First division, you get 2 new cells, but it's not an equal division. One of those gets a lot more of the cytoplasm and the mitochondria and everything, and so the smaller cells referred to as a polar body. It will continue to go through the remainder of meiosis too, but these polar bodies are really small. They're going to die. And what happens to the secondary oocyte? Well, it's kind of sitting right here, and then if it is fertilized by the sperm, bingo, all of a sudden it goes through very quickly into the second stage. This polar body is going to be too small to survive, so it's going to die. You're resulting with 1 egg or ovum that is fertilized, and now you're going to end up with your resulting zygote. So in oogenesis, how many functional cells do you end up with? Just 1. In spermatogenesis, you end up with 4. Folliculogenesis is the growth and development of those follicles. The progression of it is you have a primordial follicle, then you have a primary, then a secondary, and then a tertiary. The tertiary follicle is the one that releases that secondary oocyte during ovulation. 99% of the follicles are going to die before ovulation. So even though a female, like I said, may start with over 1 million ovum at the time of birth, a lot of those majority of those are going to die before she even reaches puberty, and then the remaining, like I said, 99% of them are going to die before being ovulated. So the stages of folliculogenesis, you have that primordial, and notice you have initially the oocyte, and then you start to get these additional supporting cells growing around it, and more of them secondary follicle. Here's now your tertiary one. Ovulation is going to occur, and if fertilization occurs, the corpus luteum is going to help keep levels of the hormones high enough to maintain the uterus for proper thickness for nutrition and implantation, basically for survival for that pregnancy. If fertilization does not occur, then this corpus luteum is going to eventually break down and disintegrate. In terms of hormonal control over the ovarian cycle, there's three main hormones. You have your GnRH, gonadotropin-releasing hormone. This is going to stimulate the release of the other two hormones. So once again, here we go with kind of a cascade thing. So GnRH is going to stimulate the release of the other two hormones, which are FSH, follicle-stimulating hormone. That's going to stimulate those follicles to grow. And then the LH, which is the luteinizing hormone. That stimulates production of a specific type of estrogen called estradiol. High concentration of estrogen is going to trigger a negative feedback loop, and that's going to then inhibit all of these. Only one dominant follicle is going to survive decreasing estrogen levels. So it's a way of, you want to stimulate the follicle to grow so that then eventually you end up with ovulation occurring, but you don't want all the follicles growing and releasing multiple oocytes at ovulation. So it allows for only one dominant follicle to survive. That dominant follicle starts to secrete high levels of estrogen again, and that's going to result in ovulation of that dominant follicle. Like I say, the collapsed follicle transforms into the corpus luteum, which then secretes progesterone. That is necessary. Progesterone is necessary for the establishment and maintenance of the pregnancy. So you start to see there's a lot of interrelationships between the different hormones and levels for making sure that if fertilization occurs, can we have that uterus ready to be prepared for implantation and then maintenance of that pregnancy. Some of you may be thinking, where's the placenta and all this? The placenta is not initially formed. Okay. If pregnancy does not occur, that corpus luteum, as I said, will break down. And so this is showing the follicular phase here and the ovulation phase over here, the different hormones such as pituitary hormones, that's the luteinizing and follicle stimulating, how they play a role, how the two are interacted together, and then finally the luteal phase down here. The uterine tubes, as I said earlier, are known as the fallopian tubes. They're also known as oviducts. They are actually not directly connected to the ovaries. They're right near them, but they're not directly attached to them. Because of contractions that occur in the tubes, and movement of the fimbriae, which are the thin, little finger-like extensions on the end right by the ovaries, that kind of pulls or attracts the ovum into the uterine tube when ovulation occurs. Fertilization. A lot of people think fertilization occurs in the uterus. It does not. Normally it will occur in the uterine tubes. So let me just say fertilization and implantation are two different things. You have to have fertilization occur first. That is when the sperm is able to penetrate the ovum and you have the resulting formation of the zygote, the new cell. That has usually to occur in the uterine tubes, and then the resulting cells will eventually move down into the uterus and implant on the uterine wall. You do not want implantation to occur in the uterine tubes because there's not enough space there for the developing embryo and resulting fetus to grow and develop. The tubes would rupture, and that's very dangerous for the mother. It can kill her. That is what is often referred to as a tubal pregnancy. So the uterine tube is the site of fertilization. The other thing to just sort of keep in mind is pelvic inflammatory disease, or PID. Can be very, very dangerous certainly if left untreated, because the uterine tubes are connected to the uterus on one end, but the other end is open so that it can receive the ovum. Well, that's open in the pelvic cavity, right? Which means, think about it, if you were to have an infection that originated or gained entrance by the vagina into the uterus, can move up the uterine tubes. Once it's in the pelvic cavity, it can go systemic and can go everywhere. And so that can be very, very dangerous. It can be fatal. It needs to be treated as soon as possible. It's also one of the reasons why, any opening, remember, of the body to the outside environment tends to have a lot of natural protective mechanisms to try to prevent infections, trying to prevent invasion, if you will. And so with the vagina, there's a lot of secretions that are flowing out to try to help flush and prevent the infection of any, say, microorganisms. One additional problem that pelvic inflammatory disease can result in, if a woman has this, it can cause scarring on the uterine tubes. If that scarring is severe, it can lead to infertility issues. So here are the ovaries over here, and these are the fallopian tubes. The fimbriae are these little finger-like extensions. And you can't see here, but over here it's drawn a little bit better so that you can see they are not attached to the ovary. So they're going to be moving, kind of creating a current. So when ovulation occurs, then the ovum will be released and drawn into the uterine tube and will eventually move down. And then, like I said, fertilization, if it's going to occur, typically will occur in here. The uterus and the cervix. The uterus, muscular organ, is going to nourish, it's going to supply support for that growing embryo. There's 3 regions to the uterus. The top portion is known as the fundus. The main middle portion of it is known as the body, and the very bottom portion of it that connects to the vagina is the cervix. There are several ligaments that help to hold the uterus in place. There's the broad, that's the main support. The broad ligament attaches to the pelvic walls laterally. The round ligament extends down to the labia majora, and then the uterosacral ligament attaches to the pelvic wall posteriorly. So they all work together to hold it in place. So on this picture down here, this would be the fundus up here, the body, and then the cervix. There's 3 layers of the uterus. The most superficial layer, this kind of, I don't even know what, darker tan, I guess, here. This thinner layer over here, that is the perimetrium. It's more like a serous membrane, so it's connective tissue. The myometrium, in this drawing right here, this thicker layer right here, that is smooth muscle. And then the endometrium, which is the innermost layer, which is this thin layer seen here. The endometrium, that will grow and thicken in response to increased levels of estrogen and progesterone. That is where implantation of that fertilized egg is going to occur. If fertilization does not occur, then that layer is shed. So that is what gets shed on a monthly, typically on average, a monthly basis. The menstrual cycle, like I say, this it's different than the ovarian cycle, but it correlates. Timings, they have to work together basically. This different stages when the uterine lining is going to be shed, it rebuilds, and then prepares for implantation. And if implantation does not occur, then it's going to be shed, rebuild, and it's going to cycle around. Average length is 28 days. That is not surprising considering that the ovarian cycle is also on average 28 days. Like I said, they're different, but they need to communicate with each other. The stages are controlled by hormones. The 3 stages are Menses phase, Proliferative phase or proliferation phase, sometimes you'll see it as that, and the Secretory phase. So the Menses phase, this is when the lining is shed. For most women, that's what you're familiar with as the first day of your period. Average, about 5 days, sometimes shorter, sometimes longer. It depends on women. It just depend, even for one woman, it can depend on stress levels, diet levels, exercise levels, all kinds of things like that play a role. It correlates to the early days of the follicular phase of the ovarian cycle. The proliferative phase, this is when the endometrial lining begins to rebuild. It's already been shed, now it has to start to rebuild. Typically, ovulation occurs on day 14, and that will signal the end of this phase. And then the final phase, the secretory phase, is the beginning of the luteal phase of the ovarian cycle. The endometrial lining is preparing for implantation. There tends to be increased fluid that's going to help support the zygote if fertilization did occur. Like I said, it's all controlled by hormones. So this diagram, which is in your book, just shows, number 1, the follicular phase, days 1 through 7, as you are going from the primary to the secondary, follicles, and tertiary, and finally, as you can see up here, the ovarian cycle. Ovulation occurs. Now you're in the luteal phase. How does that correspond to the days of the menstrual cycle? Ovulation occurs, if the menstrual cycle, you start counting day 1. That's when the first day, as I said, a woman is on her period. Typically about day 14 is when ovulation occurs. So some, obviously depending on where you are in your life and what you're wanting, some women keep very close tabs on this if they are trying to get pregnant. Is that typically ovulation occurs about day 14. And then this is shown with the menstrual cycle, menses, where you're shedding, start to rebuild, and you're preparing now the secretory phase. And down here, this is showing, once again, the different hormones. Your follicle stimulating hormones, luteinizing hormones, once again, remember, those go up relative to ovulation. So some women who are trying to get pregnant are monitoring. They see the increase of these hormones. They know, and there are tests that you can run, they know that they're about to ovulate. And then over here you can also see with estrogen and progesterone. So it's kind of nice to have everything all on one table or one chart to compare. As I said, these 2 cycles are different, but yet they have to work together. They have to be correlated together. And then in terms of the breast, the different areas, the areola, the nipple secretes lubricating fluid that's during lactation when the mother is nursing to help to protect the nipple. The mammary glands are modified sweat glands. They are producing milk. In terms of the milk production, it's going to flow from those mammary glands and the alveoli to the lactoferous ducts, to the sinuses, and then to the nipple. So they are being produced. Here, if we look at this cross section, and then they go to the lactoferous ducts, to the lactoferous sinuses, and then out the nipple. And notice there is supporting fat tissue that's helping to cushion these glands and support. Just a few extra, just kind of may not be on your study guide, but FYI informational things. Hormonal birth controls. Most of your birth control pills, what they're doing is they're providing a constant level of estrogen and progesterone. Those two hormones inhibit the release of the LH and FSH, luteinizing hormone and follicle stimulating hormone. So if those two hormones are inhibited, then that means, remember how you saw the rise of those for ovulation? If you inhibit LH and FSH, ovulation does not occur. If ovulation does not occur, then you're not going to get pregnant. Now, the older and more traditional types of birth control pills would have 21 days of the hormones, the estrogen and progesterone, and then they'd have 7 days of placebos. Because they found that oftentimes if they told a woman, okay, these 7 days you don't have to take a pill, they'd forget to get back on it. So they're basically placebos. This way you still have your period, but you must take those pills regularly to be effective. Some of the newer hormonal birth control pills do not have those placebos in there. Instead, what they are doing is giving you a constant low level of estrogen and progesterone, so it still inhibits the release of the LH and FSH, but you don't have to worry about the placebos in there. With those, typically though, you do not have a period then at all, which there's nothing scientifically wrong or adverse problems if you don't have a period. Some women just like to have them, I guess, to make sure that in their mind they know they're not pregnant. It's a personal thing that you need to decide between you and your doctor of what is the best for you and your situation. But I just want to let you know what they're doing is providing the estrogen and progesterone, which then inhibit the LH and FSH so that ovulation does not occur. And then the other thing with the reproductive system is just to be aware that what we call the secondary sexual characteristics, these become more developed as you enter into puberty. There's signs of puberty happening. For males, it's increased in the larynx size. We see the Adam's apple. That's what it's commonly referred to. The deepening of the voice, increased muscular development, growth of facial hair, axillary hair, pubic hair, increased growth of body hair overall. For females, you tend to see more fat being deposited in the hips and the breasts, so you also see the breast development, broadening of the pelvis, and growth of axillary and pubic hair as well. Broadening of the pelvis, why is this? That is physiologically and anatomically is going to be a benefit if a woman gets pregnant to be able to physically hold that developing fetus.